Hi guys, here's another video from Professional Helps. Today we're discussing amoebiasis. Amoebiasis is a common disease of the gastrointestinal tract. It occurs mainly due to poor sanitation and unhygienic lifestyle practices. The causative organism is Entomoeba histolytica. Now looking into the clinical presentation of amoebiasis, it may be either asymptomatic infection, diarrhea, dysentery, fulminant colitis or peritonitis. But the most common clinical presentation is amoebic dysentery. Now looking into the types, we have acute amoebiasis and chronic amoebiasis. Acute amoebiasis present as diarrhea or dysentery with frequent small and often bloody stools. Chronic amoebiasis can be present with gastrointestinal symptoms plus fatigue, weight loss and occasional fever. Now looking into the extra-intestinal amoebiasis, it occurs when parasite spreads to other organs. Look at this picture. The other sites affected in amoebiasis are lungs, diaphragm, liver, portal circulation, colon, perianal skin and genitals. Looking into how the disease is transmitted, transmission occurs via fecal-oral route, either directly by person-to-person contact or indirectly by eating or drinking fecally contaminated water or food. Vectors such as flies, cockroaches and rodents can also transmit the infection. The incubation period for infection is commonly 2 to 4 weeks but may range from a few days to years. Now let us look into the morphology. Entomoeba histolytica occurs in the forms trophozoite, PRECYST and CYST. Beginning with the trophozoite, it is a vegetative or growing stage of the parasite. It is irregular in shape. It is large and actively motile in freshly passed dysenteric stool, while smaller in convalescents and carriers. Trophozoites from acute dysenteric stools often contain phagocytosed erythrocytes, which is a diagnostic feature. They divide by binary fission every 8 hours. These trophozoites are killed by drying, heat and chemical sterilization. Trophozoites are not the infective stage. Precystic stage. Trophozoites undergo encystment in the lumen. Before encystment, the trophozoites extrude its food vacuoles and become round and oval to form the precyst. It contains a large glycogen vacuole and 2 chromatid bars. It then secretes a highly retractile cyst wall around it and becomes the cyst. Cystic stage. The cyst is spherical in shape. There are 3 types of cyst: early cyst, binucleate cyst and mature quadrinucleate cyst. Early cyst contains a single nucleus, a mass of glycogen and chromatid bodies. As the cyst matures, glycogen mass and chromatid bodies disappear and nucleus undergoes 2 successive mitotic divisions to form 2 and then 4 nuclei. The mature nuclei is quadrinucleate. The cyst wall is highly refractile membrane which makes it highly resistant to gastric juice and unfavorable environmental conditions. Life cycle. Entomoeba histolytica completes its life cycle in only one host, which is man. Quadrinucleate cysts are the infective forms of the parasite. Trophozoite form of the parasite is responsible for producing the characteristic lesions of amoebiasis. Man acquires the infection by intake of food and water contaminated with the cyst. As the cyst wall is resistant to the action of gastric juice, the cyst enters the small intestine undamaged. When the cyst reaches the cecum and the lower part of the ileum, due to the alkaline medium, the cyst wall is damaged by trypsin, leading to excistation. The cytoplasm gets detached from the cyst wall and amoeboid movements appear, causing a tear in the cyst wall through which quadrinucleate amoeba is liberated. This stage is called metacyst. The nuclei in the metacyst immediately undergoes division to form 8 nuclei. Each gets surrounded by its own cytoplasm, forming metacystic trophozoites. Pathogenesis and clinical features. Entomoeba histolytica causes intestinal and extra-intestinal amoebiasis. Intestinal amoebiasis. The metacystic trophozoites penetrate the columnar epithelial cells in the crypts of Lieberkühn in the colon, facilitated by its motility and the tissue enzymes histolysin. Mucosal penetration causes amoebic ulcer confined to the colon, being most numerous in the cecum and next in the sigmoidorectal region. More often, the amoeba penetrates to the submucosal layer, causing lytic necrosis and thus forming an abscess. The abscess breaks down to form an ulcer. The ulcer appears initially in the mucosa as raised nodules with pointing edges. The typical amoebic ulcer is flask-shaped. Multiple ulcers may coalesce to form large necrotic lesions with ragged and undermined edges covered with brownish slough. Clinical features of intestinal amoebiasis. The typical manifestation is dysentery. Compared to bacillary dysentery, it is usually insidious in onset and the abdominal tenderness is less and localized. The stools are large, foul-smelling and brownish black, often with blood-streaked mucus intermixed with feces. The RBCs in stools are clumped and reddish-brown in color. Cellular exudate is scanty. Charcoal-laden crystals are often present. The patient is usually afebrile and non-toxic. In fulminant colitis, there is confluent ulceration and necrosis of the colon, and the patient is febrile and toxic. Intestinal amoebiasis is not always resulting in dysentery. Quite often, there may be only diarrhea or vague abdominal symptoms, popularly called uncomfortable belly or growling abdomen. Chronic involvement of the cecum causes a condition simulating appendicitis. Now let us look at the extra-intestinal amoebiasis. Under this we have hepatic amoebiasis, pulmonary amoebiasis, metastatic amoebiasis, cutaneous amoebiasis, and genitourinary amoebiasis. Among this, we will be discussing the most common one, which is hepatic amoebiasis. Hepatic amoebiasis. It is the most common extra-intestinal amoebiasis. The history of amoebic dysentery is absent in more than 50% of cases. Several patients with amoebic colitis developed an enlarged tender liver without detectable impairment of liver function or fever. This acute hepatic involvement may be due to repeated invasion by amoeba from an active colonic infection or to toxic substance from the colon reaching the liver. In about 5 to 10% of people with intestinal amoebiasis, liver abscess may ensue. The center of abscess contains thick chocolate brown pus, anchovy pus, which is liquefied necrotic liver tissue. At the periphery, there is almost normal liver tissue which contains invading amoeba. Liver abscess may be multiple or solitary. Usually located on the right lobe of the liver, jaundice develops only when lesions are multiple or when they press on the biliary tract. Now let us see how the diagnosis is done for internal amoebiasis. The microscopic findings are foul-smelling, brown black colored stools with mucus and blood. Acidic in reaction, does not adhere to the container. Now looking at the microscopic findings, actively motile Entomoeba histolytica is seen in fresh stools. Pus cells, epithelial cells, macrophages, charcoal-laden crystals present, cellular exudates are scanty. Now looking into the diagnosis for hepatic amoebiasis, stool examination, Entomoeba histolytica is seen in 15% of cases. Liver biopsy, Entomoeba histolytica is found. In serological test, IHA, ELISA, CAMO, also known as cellulose acetate membrane precipitation. And for microscopic, pus aspirated from liver contains trophozoites. Amoeba confined to periphery. Treatment. 3 classes of drugs are used: luminal amoebicides, tissue amoebicides, both luminal and tissue amoebicides. Under luminal amoebicides, we have uroquinol, paromomycin, and tetracycline act in the intestinal lumen but not in tissues. Tissue amoebicides. Chloroquine is effective in systemic infection but less effective in the intestine. Both luminal and tissue amoebicides. Metronidazole and related compounds act on both sides and they are the drug of choice for treating amoebic colitis and amoebic liver abscess. Oral rehydration and electrode replacement should be given. Prophylaxis. Detection and treatment of carriers and avoid intake of contaminated food and water.